or last but not least, we're going to give pass to the next presentation by Dr. Parolini about the frontiers of subtraction laser. So far, we've talked about the classical indications. She will talk about less usual causes of subretinal fluid and her results by treating them with subtraction laser. Please, Barbara.
Thank you, Alejandro. All right, so this talk is dedicated to expose my experience in treating a subretinal fluid with the micropulse laser. I started to use this technology in 2016, always with the same device and always with the same parameters for different types of indication. But I will focus this talk reporting the result on the treatment of subretinal fluid secondary to causes other than central serous chorioretinopathy, and in particular, macular detachment in optic pit, retained subretinal fluid after retinal detachment surgery, and macular detachment in myopic traction maculopathy. And therefore, as you can imagine, I cannot report the results of clinical trial, but just my experience in a case series. These are the parameters that I've always been using. As I said, I started in 2016. There were no guidelines. So in order to be consistent and able to collect good data, I decided to always follow the parameters suggested by the company. The only parameter that was not suggested was the number of spots. And I arbitrarily decided to always use 400 spots when the treatment was focused on the macula, and enlarging the area and the number of spots where the subretinal fluid was also extramacular or outside the arcades. Let's start with subretinal fluid secondary to optic pit. I have a case series of 6 eyes. I've treated many more optic pit macular detachment, but these are the ones that I have treated with the micropulse laser. One was a case that was totally resolved by the laser. 2 were partially resolved by the laser, and then I had to switch them to surgery. And 3 were retreatment after surgery for residual subretinal fluid. The first case is a male, 55 years old. He has subretinal fluid already for a long time. Visual acuity is 3/10. And this is the day where I do the first session. But then here you see the follow-ups and the progression of the case toward the improvement, anatomical improvement, but also functional improvement, as shown here, where I compare the baseline image and where the visual function was 3/10 with the last follow-up where the visual function is 6/10. You see almost a total disappearance of the subretinal fluid, and the microperimetry is looking good. This is very recent, and so this is the last follow-up. A different case, a child, she is a female, 10 years old. She has had macular detachment for 1 year or maybe more. Vision now is 3/10. And she is a child, vision is not so bad. This is the first approach. I decide not to take her immediately to surgery, but to try micropulse laser. So I start with 3 sessions on a bi-monthly base. Please look that at the moment of start, she has a hyperopic shift of +4. This is her actual reflection, +4. The first 3 lasers do not seem to be so effective, but with the time, she shows a progressive improvement. The subretinal fluid is decreasing, vision is improving, and the refraction is going down, +2.5 and then +1.5, mirroring the reabsorption of the fluid. But then, after 1 year, the macular detachment has a relapse, and so I decide to take her to surgery. I perform pars plana vitrectomy, ILM peeling in the peripapillary area, and an ILM flap reverted on the pit gas and face down positioning, and this is the actual result. But even after surgery, in these cases, the subretinal fluid can relapse in time. So this is a male, 32 years of age, that I have treated with the very same surgery in December 2015, initially with a good success, but 2 years later, he has a relapse in subretinal fluid. So I already treated him with surgery. I decided to try micropulse laser, one treatment every year, and I observe a progression, a progressive improvement. I haven't treated him in a while, and it's been almost 6 years now since the first laser treatment, and vision is still good, and he does not show any relapse so far. So what about subretinal fluid after retinal detachment surgery? We all know that we might observe pockets of subretinal fluid retain, especially after episcleral surgery, but sometimes they are not pocketed, they are huge bolus detachment, even if the breaks are completely sealed. Look at this man, he's 57 years of age, he had an encircling buckle. The buckle has sealed the break, but he has these remnants of subretinal fluid for more than 10 months now. So I tried the laser in the area of subretinal fluid, and I can see a reabsorption 1 month later and 2 months, just one laser treatment. So in a different case, I also try to treat the submacular area. She's a female, 48 years of age. She had encircling buckle and cryotherapy. Again, she had subretinal fluid for more than 10 months, and she came to me with 7.10 vision. Because usually colleagues don't treat this patient. What they tell the patients is wait and the fluid will go away. But sometimes this fluid doesn't go away for a very long time. And this is a progressive reabsorption in time. So here you see the results after 3 lasers. Vision is going up, and this is 11 months after 3 lasers. Vision is very good, and she has a full restoration of visual field. This is another example, different eye, different patient, same condition. And when you look at this patient, the color picture don't tell you that they have subretinal fluid because it's a very shallow detachment. You don't see it even with slit lamp. But even if she had a very good improvement in vision, and this is the same for every patient, if you watch the autofluorescence, you see where the long-standing subretinal fluid has been. And certainly that corresponds to a damage that you can check in the visual field. So that's why I think that that type of subretinal fluid should be treated immediately. I have many other cases just confirming what I told you, another patient and another patient. So let's change subject. I was amazed to see that I could treat subretinal fluid in myopic traction maculopathy in stage A and B, meaning without full thickness macular hole. Look at this 75 years of age female. She has a schisis plus a foveal detachment, and I apply multiple laser sessions, and I can observe a progressive improvement in the subretinal fluid, and finally a total disappearance with an improvement in vision and in microperimetry. And I was so surprised because that event told me not only that I could treat this patient with a laser, but also that maybe myopic traction maculopathy is not only about traction. Maybe also the RPE pump can be deficient in this patient as well. As we know, they have a very thin choroid. And so stimulating the RPE in those cases might have a role as well. This is another patient confirming the same theory. I had operated the other eye with macular buckle for retinal detachment plus full thickness macular hole, and she had a detachment in the other eye as well. So I treat this patient, this eye with the micropulse laser, and surprisingly, I found a great improvement just a few months after one session. However, MTM progresses. It is an evolving disease. So 2 years later, she presents with ascesis again, and then a small foveal detachment. So I decide to take her to surgery. So in summary, the story of this girl is that she started with the macular detachment in both eyes. She has very long eyes, more than 35, the right, and more than 36, the left. And now she's very well with the macular buckle in both eyes. I observed that subretinal fluid secondary to tilted disc syndrome cannot be treated with micropulse laser. It is disappointing. We do no harm, but no good. I observed no complication with the actual parameters. So in conclusion, I think that micropulse laser is very effective on any type of subretinal fluid except for the tilted disc syndrome. Although the results require time and multiple treatments with the actual parameters, the result is persistent in retained subretinal fluid secondary to retinal detachment surgery, while the pathology might relapse in MTM and optic peak because they are evolving diseases. But it might be helpful, the laser might be helpful in delaying the surgical decision, for instance, in children, in one-eyed patient, in patient that already had a surgery. The parameters maybe could be changed to obtain a faster and better recovery. But with the current parameter, the treatment is safe. We need to be able to answer this remaining question, which is the best interval between treatments. In my experience, I think that the shorter, the better. It seems that when the patient I have treated on a monthly basis, the result was better. And maybe we could be able to still optimize the parameters to optimize the result. Thank you.